class. We have no.
In occupational diseases?
No, our group we have internal medicine.
Oh, I'm sorry, maybe there was a confusion. So this meeting, this lecture concerns probably only those students, those groups, which have occupational diseases by the timetable now. Maybe there was a confusion.
So teacher, you will make the lecture in another time because now we have a class.
Yes, maybe there was a confusion. So if there is an overlap, you may do your work, while as soon and as far as I'm online, I'll do my best to deliver the lecture. So may go out if you wish. I'll continue with the lecture to record it for you and to make it available later, okay?
But we will not take absent, yes, teacher?
Yes, yes, of course.
Okay, thank you.
Thank you. Okay, so anyway, I'm going to deliver the material. So this will be a recording from my mobile phone screen. Unfortunately, I don't have any other chance to deliver the lecture at the moment because of no electricity, no other devices or connections. My name is Oleksiy Kalmykov. I'm professor of the Department of Internal and Occupational Diseases of Kharkiv National Medical University. And today we have the lecture in occupational diseases. It's the very first lecture, introductory, and the second topic of our today's lecture is going to be so-called occupational dust pathology, more specifically pneumoconiosis. As soon as we have started later than I have expected, probably I will conduct this lecture without breaks and upload this recording to the YouTube channel and then distribute the link to it to your emails. And you may get all the material as well, uh, maybe give a feedback from this lecture, and so on. So you're welcome at our department at the course of occupational diseases. Here is the one of last photographs of our staff, teaching staff at our department. Unfortunately, some of these people have died already, and some new colleagues added. We have two clinical bases at our department. The clinics of Scientific Research Institute of Labor Hygiene and Occupational Diseases of Kharkiv National Medical University with pulmonologic and cardiologic profiles. It is situated at Trinkeler Street 6 in Kharkiv, Ukraine, and two more, Railroad Clinical Hospital with pulmonologic, rheumatologic, hematologic profiles, and regional military hospital with multiple profiles such as gastroenterologic, nephrologic, cardiologic, pulmonologic, and others. You'll have your practical classes according to your timetable, and our educational plan includes 3 lections, 3 practical classes, and writing a case history. As you can see on the slide, the thematic plans of lectures and practical classes correspond to each other, and they include Introduction and Dust Pathology, the second one, Occupational Diseases Caused by Physical Agents, and the third one, Occupational Intoxications. The routine classes are distributed by points according to what is stated on the screen. Uh, 40, 32, and 24 points per mark. And finally, at final control, you are expected to give answers on basic level, first quality level, or can undergo the examination or the conversation, discussion for second quality level with according points, as you can see on this slide. Some additional points may be added for your individual research work of students. And let me introduce the main directions of our research work at our departments. So basically we have 2 directions, internal diseases of therapy and occupational pathology. The objects of our researches are chronic bronchitis, chronic obstructive pulmonary disease, bronchial asthma, and pneumoconiosis, in other words, pulmonological profile, in combination with arterial hypertension or ischemic heart disease or cardiac coronary disease, or with vibration disease and cor pulmonale and heart failure. The aim of our research is to optimize the diagnosis, treatment, prophylaxis of mentioned diseases by evaluation of pathogenic factors, by development of prognostic potential of these factors, and assessment of treatment efficacy. The pathogenic aspects which we are interested in and some other aspects which we study include clinical and hygienic aspects, in other words, correlation or relation of influence of occupational hazards on appropriate systems of organs of workers' organism. Then evaluation of central hemodynamics. By this we understand mostly heart's parameters, and we evaluate them by mostly ultrasound investigation. Immune inflammation. We check for markers of immunity, both cellular and humoral, and regulators of inflammatory responses and reactions such as cytokines with interleukins and tumor necrotic factor and so on. Mechanisms of fibrosis by evaluation of metabolites of collagen and etc. Endothelial dysfunction. We evaluated both instrumentally by ultrasound investigation of carotid arteries and by laboratory markers. Oxidative stress, it's evaluated by most laboratory markers and genetic factors, their relation to the speed and severity of development of occupational or internal diseases. The forms of students' participation in research work include individual investigations with the usual component of any other scientific research with analysis and description and delivering the reports at scientific forums and attending lectures, seminars, and so on. So you're kindly welcome if you are interested in taking part in research. For instance, a part of this, I have some extra proposition to those medical students who are interested in development of practical medical projects to improve their skills in fundraising for scientific research. I could share my own experience and even conduct education of you in the field of fundraising for scientific medical researches or studies. So let's continue with our today's introductory lecture, introductory topic, the general issues of occupational pathology. By definition, occupational diseases may be described both as a part of clinical medicine involved in investigation of diseases caused by different hazards of a production environment or factors of working process, so as a branch of medicine, right? Or as a group of diseases caused by different hazards of production environment or factors of working process. The occupational morbidity varies from 1 to 10 approximately per 10,000 workers in different regions of the world. And these incidence or relevance depends on the level of development of healthcare system and income in these countries and so on. The occupational hazards might be classified into 5 main groups and 2 additional. The main groups include dust, different kinds of dust, silica-containing or silicate-containing, carbon, metallic, organic, mixed. Then second group of chemicals, organic, inorganic, aromatic, and so on, compounds. Then third group, physical factors or agents such as vibration, noise, ultra and infrasound, increase or decrease atmospheric pressure and temperature, electromagnetic emission, and influence of moving machines and mechanisms. The fourth group may be described as biological agents of bacterial, viral, protozoal, fungal origin, or even influence of helminths. And the fifth main group is functional agents. It's mostly overstraining physical or neuropsychological and influence of monotony and so on. And the two additional are allergic agents and carcinogenic agents. So again, dust, chemical, physical, biological, and functional, and two additional allergic and carcinogenic. Why do we have such a distribution? Allergic may belong to both dust or chemical or biological groups, while it concerns the significantly different kind of pathogenesis. That's why we have such a subgroup, allergic. Same for carcinogenic. The oncological pathology might be caused both by some types of dust, such as, for example, asbestos containing and so on, by chemicals, such as heterocyclic compounds and so on, by physical agents such as ionizing radiation and so on. While this pathology has its own specific kind of development, the mechanism of development. Carcinogenic is the second additional group of occupational hazards. As you can see, they could be different targets of each type of or representative of occupational hazards all over the organism. And there are five basic pathophysiological aspects of the influence of occupational hazards on the organism, such as multiple factor impacts in every certain working place simultaneously. Many different agents are influencing on the organism simultaneously at one at the same time. For example, in miners, they undergo influence of both overstating mental and physical, then influence of dust, influence of overheating, then influence of some chemicals as well, and so on, simultaneously. Then, second common pathophysiological aspect is monoetiology of a disease. Each certain occupational disease has only one certain occupational cause. The diseases may be conditioned by a set of agents, but caused by only one of them. For example, vibration disease is caused by vibration only, while it is conditioned. Some precipitating agents might be overcooling, increased humidity, overstraining, microtraumatization, and many others. But solely they cannot cause the development of the disease, of vibration disease itself. Next, polytropicity of hazards. Each certain hazard, as it is represented on the slide, simultaneously influences on different systems of organs. For example, on this slide, lead influences on nervous system, on cardiovascular system, on liver, and generally gastrointestinal tract, and on bones, it is illustrated here, right? So, polytropicity of hazards. As soon as one and certain and same hazard influences on different organs and systems, we expect polysyndrome manifestation, simultaneous development of symptoms from different organs, from different systems. And the fifth aspect is the essential role of individual peculiarities in the development of a disease. For example, there could be both predisposition to development of disease, for example, to development of blood pathology in those who undergo influence of aromatic hydrocarbons, if these people work in some hazardous environment, or vice versa, resistance. For example, in people working in mines, only parts of them suffer from dust pathology, such as chronic bronchitis or chronic obstructive pulmonary disease or even pneumoconiosis, and the rest of workers do not. So they have some level of resistance. So again, five aspects of pathophysiology of occupational disease: multiple factor impact, monoetiology, polytropicity, polysyndrome manifestation, and role of individual peculiarities. The classifications of occupational diseases are different, and I'll represent main of them for you now. So, occupational diseases may be classified by specificity into specific and non-specific or conditional. And the specific are sub-classified or decomposed into absolutely specific or genuine and relatively specific. By absolutely specific, we understand that these diseases develop only under the influence of occupational agents and cannot develop in non-occupational conditions at all, such as there are only two representatives of this group, vibration disease and pneumoconiosis. And there is a group of relatively specific, which mostly, much more often develop as occupational diseases, but by some conditions, they may also develop in non-occupational situation, such as radiation disease, intoxications with manganese or lead or mercury or arsenic. Mostly, they develop in industrial conditions, while it's possible to develop in non-occupational as well. And of course, the much more diseases develop as non-specific or conditional in certain conditions under the influence of occupational hazards. The good examples are chronic bronchitis, for example. It could be caused by infection, it's mostly non-occupational, and dust. In this case, it's mostly occupational. Or bronchial asthma, again, it may be caused by non-occupational factors at all, or by some agents which are present at working environment, and therefore, in this case, bronchial asthma becomes occupational one. The classification by etiology includes the same principle as we discussed with you for occupational agents. Occupational disease caused by dust, caused by chemicals, caused by overstraining, by physical agents, by biological agents, and two additional allergic occupational diseases and oncological. There is also one more approach to classification of occupational diseases by systems. It's useful in the practical aspect. Occupational diseases with, take care, predominant affection of respiratory organs, or blood, and nervous system, digestive, hepatobiliary system, sensory organs, locomotor system, or urinary tract, so urinary system. As you can see, it's important to understand that there is only predominant affection because every time we have influence of any occupational agent, we have multiple affection of different systems and organs. Good. So the one of most important aspects and slides in this lecture is this one, the principles of diagnosis of occupational diseases. We take into account the occupation of the person, and we take this information both from official record cards and from words of the person, where he has been working, in what profession, and so on. Then, working experience or duration of work. For how long have he has been working in this profession, in these conditions as well. The third one, which is essential for diagnosis of occupational diseases, is working conditions. In what exact working conditions did he work? And we wonder about these from two possible ways or origins, sources, from the words of the person and obligatory from official documentation, because people rather often uh, either boast at all, they lie, or they may aggravate, or and so on. So we have to base our decision on most relevant or most evidence or evidence-based information in this case, and we wonder about the following five aspects of working conditions. First, what exact agent or agents have been influencing on this person? Just name them. Next, second, at what intensity did this agent influence on the of this person? By intensity, you understand, for example, concentration of some substance or dust in air of working area, or there could be a level of ionizing radiation, intensity of ionizing or non-ionizing radiation, which have been influencing on the organism. Third aspect of sanitary hygienic characteristic is the maximum permissible value. By this, we understand that maximum permissible concentration or maximum permissible level of, for example, noise. This is the maximal intensity of influence of this agent, which still does not cause the development of the disease. For example, the MPC or maximum permissible concentration for dust containing free silicon dioxide is 1 milligrams per cubic meter, while MPC, maximum permissible concentration of, for example, carbon containing dust, for example, coal dust, is 6 milligrams per cubic meter. Oh, not milligrams, but grams per cubic meter. Good. And the fourth aspect of working conditions means what prophylactic agents, what prophylactic measures have been used to protect the workers against occupational hazards. And the fifth aspect of occupational or working conditions is the efficacy of these measures. Okay, so the next aspect or diagnostic criteria is occupational morbidity. By occupational morbidity and its importance, we understand, for example, how many people have got ill from the same or similar working place as our patients, and with what exact diseases. So if we get this information, we might be already aware about the probability of their development in our patient as well. So the probability of development of such diseases is relatively higher. Next, the fifth aspect of diagnostic criteria is health condition before work. The sixth one during the work, and seventh after discharge from the work. Why it is important? The usual and most typical case is when the people are employed relatively healthy, then gradually some disturbances appear and grow in their intensity, progress, and finally they could be either recovery or some residual changes or even progression of the disease. And we get this information from interview or medical documentation and so on. The eighth aspect of diagnostic criteria is the type of course of the disease. Different types of occupational diseases have their own peculiarities of course. For example, let us take occupational chronic bronchitis. If it is caused by dust, the onset is latent at all. We cannot recover or reveal when this disease has started. And vice versa, if we have occupational chronic bronchitis caused by irritative substances, we also name it occupational chronic toxic bronchitis. In this case, these people definitely remember the exact even date of the onset because it is sharp, it is acute, it is characterized by intensive irritative cough and so on. And same for the course and the result of treatment and so on. Each of these diseases have or has its own peculiarities of onset and course. The eighth aspect of diagnostic criteria is identification of certain signs. I advise you to distinguish three types of signs: specific, typical, and non-specific. By specific signs, we understand that these signs develop only in this certain disease and never can develop in any other diseases, any other pathologies. For example, in dust pathology, one of specific signs and even only specific sign is granuloma, the specific granuloma. It's specific for silicosis, it's named silicoma, and so on. It contains, again, very specifically oriented or arranged layers of cells and even dust particles, inclusions, and so on. Then, typical signs are those which are very often in this disease, but by some conditions may develop in others. For example, irritative cough. Potentially irritative cough may develop even in infectious origin of the bronchitis, while it's highly typical, highly often, especially in chronic occupational bronchitis caused by irritative toxic substances. And non-specific signs include those ones which usually present in the wide range of different diseases. They're also common in this certain disease. For example, general fatigue, decrease of workability, maybe fever, and so on. They develop their general signs. They may develop in a wide range of different diseases, but may be possible also in inflammatory occupationally caused diseases. The uh, diagnostic criteria number 10 is excluding of other causes, occupational or non-occupational, that may lead to the development of the disease. Only if we exclude non-occupational causes, we can prove that this is definitely occupational. And take care, please, that the proving of the final diagnosis of occupational disease is made by commission, a group of experts. Good. The final one in the introduction, in the general issues of occupational diseases, are the measures of prophylaxis of occupational disease. There are different groups of these prophylactic measures, such as primary or secondary, it's populational or individual, and so on. Many of them are represented on the slide. Improvement of technological process, even automatization of it without any involvement of human being. Then hygienic monitoring of working conditions and therefore reaction to their uh, exceeding maximum permissible values in time, and by this preventing of development of occupational disease. Then use of individual protection measures such as special clothes, masks, headphones, and so on. medical social measures such as extra days to vacancy period to vacation and maybe some extra payment for these people, shortened duration of the working day, and so on. Then the next measure may be uh, useful for you, and maybe sometime you as medical doctor will join a group of experts for preliminary and periodical medical checkups. The aim of preliminary medical checkup is to prevent employment of a predisposed person, and periodical medical checkups are performed to reveal some changes of the organism state at pre-disease, pre-nosologic stage, before the development of the disease at all, at the very early stages. The dynamic follow-up is for evaluation of health condition during the period of work of the person, and rehabilitation to prevent relapse of the occupational disease, and reasonable employment. As you can see, you have the relevant textbook in occupational diseases. It's available in electronic form, I mean digital, or in book. And there is a set of international textbooks and international online resources which might be useful for you in your study of occupational diseases. So this is that about the introduction to occupational diseases, and now I'll continue with, let me see, with our second topic for today. It's occupational dust pathology. Let me find it, just one moment. Let me find the presentation. Where is it? General dust pathology. Here it is. Okay. So the second topic is dedicated to, for instance, dear students, do you have any questions at the moment regarding general issues of occupational diseases? Hello? Are you there?
Hello, teacher.
Hello? Do you have any questions regarding general issues of occupational diseases?
No, teacher. Thank you.
Okay, so I'll continue with dust pathology. There are following diseases we are going to discuss with you today, or if we'll not be in time, you'll get this presentation and you may look through. As you can see, there are 123 slides there, so it might be useful for you, and I don't think that we'll be in time and discuss at our lecture, because previously we had 3 lectures for this certain topic. Good. So let's start from pneumoconiosis. By definition, pneumoconiosis is an occupational disease caused by dust and characterized by affection of the lungs with diffuse distribution of pneumofibrosis, predominantly in middle and lower regions, and bilaterally. So again, the term pneumoconiosis comes from Greek pneumon, lung, and cornea, dust, and osis, chronic disease. So it's chronic disease of lungs caused by dust, literally. The relevance, the incidence of this group of diseases varies from 1 to 10 again in different regions of the world. And we have 5 types, according to modern etiological classification of pneumoconiosis. We have 5 types of pneumoconiosis, depending on the chemical content of the dust. If there is mostly, or there is present at least, the silicon or silica dioxide or quartz in dust, possibly this may cause development of silicosis. If there are silicates containing dust, there could be different kinds of dust, such as asbestos or cement and others. There is development of group, we name it silicatosis, silicatosis. If there is carbon-containing dust, we name, and there is development of pneumoconiosis, we name this kind of pneumoconiosis as carboconiosis. And there are certain types of carboconiosis, such as anthracosis caused by coal dust, graphitosis caused by graphite dust and containing dust, and so on. The fourth type of pneumoconiosis is metalloconiosis, metal-containing dust. If it contains iron, we name this kind of dust siderosis. If aluminium, aluminosis, and so on. And the very last one group is named hypersensitivity pneumonitis or pneumonitis. They are mostly caused by those kinds of dust which possess sensibilization and allergic response. So the typical representatives of these dusts or these pneumoconiosis are berylliosis caused by beryllium, bisonosis caused by organic dust, and so on, such as toxic fibrosing alveolitis, etc. There is also one other approach to classification of pneumoconiosis based on etiology, and this kind of classification depends on the content or quantity of silicon dioxide in dust. Why it's reasonable? Because in the majority of cases, silicon dioxide is present in more or less quantity, but present in the majority of kinds of dust. And if it exceeds 10%, we name this pneumoconiosis caused by high and moderately fibrogenic dust or fibrogenous dust. If it is less than 10% of silicon dioxide, we name the pneumoconiosis caused by low fibrogenic or fibrogenous dust. And the third type is, again, hypersensitivity pneumonitis caused by dust or industrial aerosol of toxicollergic influence. There is also a rentgenological approach to classification of pneumoconiosis. On the slide, you might see the more detailed type of classification. It's enough if you remember the so-called zero stage, its initial fibrosis, interstitial type of fibrosis, nodular, and nodal. So there are three stages of developed pneumofibrosis: interstitial, nodular, and nodal, and one more as zero stage, as pre-disease initial fibrosis. As you can see, they also differentiated by the character of shadows, by intensity and distribution, and localization, but there are some details, and they might be useful for you if you want to become a specialist in medical radiology, in rentgenology, and so on. Basically, it's enough if you remember interstitial, nodular, and nodal types of pneumoconiosis based on X-ray. Here is the other detailization. On these slides, I try to represent the approach to classification of pneumoconiosis based on severity by stages. There are 3 stages totally. And mostly these stages depend on intensity of pneumofibrosis at its type and distribution, and the clinical condition of the person, development of complications of pneumoconiosis. So let's discuss in brief the X-ray approach to diagnosis of the stage of pneumoconiosis. As you can see on the slide, comparing with normal X-ray, in patients with pneumoconiosis, they represent increased transparency. So in other words, emphysematous type of X-ray. Then enlargement of lungs roots, and they become more condensed, more dense. Here is the Here is the illustration, even such a drawing to highlight main changes. As you can see, a part of hardening of lung roots and lung pattern. There is also more or less expressed reaction of heart because of increased resistance of vessels in minor circulation. There is enlargement, primary enlargement of right ventricle, then right atrium, and sometimes secondary, there could be also systemic arterial hypertension and appropriate changes of left parts of lungs, pardon, of heart. So in brief, at the very early stage, we observe mostly interstitial type of fibrosis or sometimes nodular. At second stage, you can see that there is even more expressed emphysema of pulmonary emphysema and a hardening of lung roots and deformation of lung pattern and enlargement of heart itself due to mostly right ventricle. And at third stage, we always observe some complications, some severe complications of pneumoconiosis with, of course, progression of the basic signs of pneumoconiosis. So on this slide, you may compare a normal X-ray, first stage, second stage, and even third stage of pneumoconiosis. The clinical functional characteristics or approach to classification of pneumoconiosis include 5 aspects: classification by stages, by complications, by lung ventilation function, by development type, and by chorus. Let's discuss them one by one. We have already discussed with you that stages of pneumoconiosis is connected with intensity and type of pneumofibrosis, severity of structural changes in lungs, and development of complications. Complications include secondary bronchitis, emphysema, insufficiency, chronic obstructive pulmonary disease, inflammatory changes such as pneumonia, sensibilization to either dust or some non-occupational uh, agents, and development of bronchial asthma, development of bronchiectasis, or secondary infections like tuberculosis, or pneumothorax. For instance, pneumothorax, spontaneous pneumothorax is a feature, is at high risk in silicosis, for example. Then malignization, form of cancer of lungs, development of cor pulmonale and even heart failure, and some extrapulmonary changes like lymphadenitis and so on, rheumatoid arthritis as well. Then we also take into account the lung ventilation disturbances. They are genuine, are restrictive, so there is limitation of inspiration because of making tissues of lungs more dense and less elastic, decrease of elasticity of them. While they also optionally could be overlap with obstructive and even diffusive disturbance of diffusion of gases through alveolar capillary membrane, or mixed. And there are four types of development and four types of course of pneumoconiosis. Let's focus on them on next slide. So, by development, we distinguish four types: acute development of pneumoconiosis, fast, slow, and late. What do I understand by acute? It's when pneumoconiosis develops in less than 5 years of exposure to the dust. If it lasts for 5 to 10 years until the initial signs of pneumoconiosis develop, we name this type of development as fast. If it takes more than 10 years of exposure until first signs of pneumoconiosis, we name this condition, this type of development, as slow. And if this person has been already discharged from the work, from eliminated from the contact with dust at all, and more than 5 years passed since this time until development of the first signs of pneumoconiosis, we name this development as late. Acute, fast, slow, and late. I hope I have explained this clearly, and I promise to explain four types of course of pneumoconiosis. We distinguish quickly progressive, when it takes less than 5 years from stage to stage of the disease progression, then slowly progressive, when it takes more than 5 to 10 years of course from stage to stage progression. Then third type of course, stable course, with no progression of pneumoconiosis to the next stage for more than 10 years. And regressive, when there is involution of pneumoconiosis. So let's focus on different types of pneumoconiosis. Silicosis. It's a type of pneumoconiosis caused by dust containing free silicon dioxide. The maximum permissible silicon dioxide is 1 to 4 milligrams per cubic meter. Why there is such a range, 1 or 4 or even 6 sometimes? It depends on the portion of dust taken by silicon dioxide, because with very few exceptions, workers undergo influence of mixed types of dust, with some only part or half or some other part containing silicon dioxide, and other might be carbon or metal or some other. That's why we have different standards of MPC for these kinds of dust. The main industries in which there is a relatively higher risk of development of silicosis include mining, metallurgic, machine building of foundry, especially in foundry departments, production of fire refractory materials, construction of tunnels, explosives experts, production of building materials, and so on. The pathogenesis of silicosis development has different components. In the textbook, you may get more detailed discussion or description. On this slide, I highlight three components: mechanical damage of cellular structures, then colloid absorptive mechanism of influence when there is formation of free radicals and secondary affection with them, and immune component of pathogenesis when there is sensibilization, or at least if no sensibilization, at least immune reaction to secondary products of reactions. And finally, this result in diffuse fibrosis. You may see on the slide the fibrotic nodules. So it looks like so that dust influences on the tissues directly or indirectly with production of free radicals, with involvement of macrophages and development of inflammation and entrance of extra macrophages again, and production of collagen and remodeling of lung structure, and a set of extrapulmonary effects of silicon-containing dust, and therefore combination of silicosis with some extrapulmonary conditions and pathology. Here is on the slide the so-called coniophages. There are macrophages containing particles of dust inside them, taken from the lung of the patient. Here is one more example of silicoma. It's granuloma, taken from the lungs by biopsy. Here is the outlook of lungs from patient with pneumoconiosis, in this case silicosis. You can see how intensive is the deformation of lungs due to fibrosis. And typically, these patients represent some extrapulmonary, not only connected to lungs, affections, such as Kaplan-Collinet syndrome. It's combination of lung affections and rheumatoid arthritis, or dermatomyositis with affection of skin and lungs simultaneously. As you can see, typically there is a combination of silicosis with some rheumatic or rheumatoid diseases. And of course, from side of clinical manifestation, we detect chronic cough, usually dry, then dyspnea, mostly of inspiratory type, and pain in chest. It's bilateral, connected with or associated with phases of lung excursion, with breathing phases. Here are some examples of different types of X-ray changes typical for silicosis. It's interstitial type of silicosis, the minimal intensity. Here is a combination of interstitial and nodular. In pneumofibrosis, you may see some nodules here, right? Then on this slide, there is also a combination of interstitial and nodular, while interstitial component is more expressed than previously. It's more expressed. And here is the complicated case. We name this form of pneumoconiosis as tumorous. It looks like there are tumors inside the lungs. It's because of formation of nodes, accumulation of many nodules in one common node, and distribution across the lungs bilaterally with intensive emphysema of lungs, with complication with tuberculosis in this case, and pleural effusions. So the medical checkups for people who work under the influence of free silica-containing dust includes the annual medical checkups, including therapeutists, otorhinolaryngologists, and by indications also dermatologists, pediatrician, and oncologists, with obligatory investigations, uh, X-ray of chest, spirography or spirometry, and the contraindications of work in contact with dust in general and silica containing as well is dystrophic changes of upper respiratory tract, the chronic respiratory pathology, the expressed nasal septum deviation because of redistribution of airstream, recurrent diseases of skin, and tuberculosis of lungs. In case if the diagnosis of occupational disease, in this case pneumoconiosis, more specifically silicosis, has been performed, the expertise of workability includes at first stage reasonable employment and third invalidity group, at second stage invalidity group of third or second stages, and at third stage second groups, and third stage second or first invalidity groups, and significant limitation of workability. So, the peculiarities of silicosis include risk of acute development, continuous progressing, asymptomatic course, predominantly nodular type of fibrosis, and development of extrapulmonary changes, Kaplan-Collins syndrome, etc. Just one moment. Just a few seconds. Лешечка, дали свет, сынок. Ага. Okay. The next type of pneumoconiosis, which I'd like to discuss with you, is asbestosis. It's pneumoconiosis caused by dust containing asbestos. As you can see, the maximum permissible concentration for asbestos dust is slightly different from silicon dioxide, and it's 2 to 8 milligrams per cubic meter, while for silica containing it was 1 to 4 milligrams per cubic meter. The main places where there is a relatively high risk of development of asbestosis include mining of asbestos, production of fire isolation materials or roof covering, or water pipes production, and breaks, blocks, and so on. And the average working experience enough for development of asbestosis is, in the majority of cases, more than 10 years. The pathogenesis, the mechanisms of development include mechanical damage of tissues and possibly chemical influence with oncogenic mechanism. And finally, we observe diffuse fibrosis and risk of neoplasms formation. Here is the illustration of places, in this case in Canada, of mining of asbestos, its transportation. Here is the fibrous structure of this mineral. One more illustration of how fine are the fibers of asbestos, and therefore the higher risk of development of pneumoconiosis, and making depositions of these kinds of dust in the lungs and even all over the organism, because some part of these dust particles might be distributed with blood or lymph all over the organism. And here is the microspecimen with the inclusion of asbestos fiber inside it and the development of cellular reaction. And you may see some more fibers of asbestos. And finally, there is development of fibrosis. Look here on this slide how intensive might be such a foci of plagues on the pleura inside the tissue parenchyma of lungs with significant deformation of lungs. Here is one more example of pleural plagues. Here is the cross-section of this plague with the layer of inflammatory cells, more condensed fibers of collagen, and superficial parts. Here is the germinative layer of epithelial coverings and uh, asbestos fibers might even penetrate the cells, not only in between them, but also inside them, with further formation of asbestos bodies. By asbestos bodies, we understand that there is the fiber of asbestos covered by the layer of proteins, and this might be even stored somewhere in the cells, stored. The clinical manifestation of asbestosis is much more variable comparing with silicosis and may include typical bronchitic syndrome, pleural friction rub, bronchial obstruction. For instance, obstruction is not typical for silicosis but typical for asbestosis, emphysema of lungs development at early stages. And in this relation, it's similar to to silicosis. Development of pneumosclerosis, intensive deformation of lungs, intoxication syndrome, dyspepsia, asthenia, lung insufficiency, chronic pulmonale, and even asbestos wars. Let's focus on this symptom you may see on the slide. Sometimes due to storage of these fibers of asbestos inside the germinative layer of the skin, there is a stimulation of cellular proliferation and development of such neoplasms in form of wars. Here are some X-rays from patients with asbestosis. You may see how intensive is the emphysema and pleural effusions or pleural fibrosis as well. One more example of these changes and one more illustration with pleural plagues and hardening of the pleura, diaphragmal part of pleura, and more expressed asbestos. It's very rare when asbestosis reaches such an intensive distribution and so severe course. Usually these changes develop gradually or patients develop cancer of lungs and die early, unfortunately. Okay, so the peculiarities of asbestosis include clinical symptoms precede X-ray findings. I mean that bronchitic syndrome is much more expressed than in case of silicosis, and obstructive component is also common for these patients. So these patients admit to doctor at much earlier stages. And the second peculiarity is that even in third stage pneumofibrosis is not so expressed as in silicosis. Then, there is no inclination of quick progressing in patients with asbestosis. And then the severity of state is determined by complications, both bronchial obstruction or secondary infection or complication with oncological pathology, cancer, and so on. There is a high risk of cancer and mesothelioma development and extrapulmonary manifestation. If you remember, we discussed with you such as asbestos warts and so on. The next groups include carboconiosis, metalloconiosis, and hypersensitivity pneumonitis. As soon as it's almost time to finish the lecture, I'll highlight the main things for you, and the rest you may get from presentation and from textbook and some other sources. Or you may ask me and I'll advise you any. So let's continue with anthracosis. It's a representative of carboconiosis. It's caused by carbon-containing dust, mostly coal dust, not mostly, but specifically coal dust. So the main industries include mining, coal preparation, heating and boiling. There is mostly mechanical damage of the tissues. You may see extra hard depositions of these dust particles inside the tissues. Here is the macro specimen of the lung, also with depositions. In clinical manifestation, these patients mostly complain of cough, dyspnea, and pain in chest. On physical examination, you might observe enlargement of chest of emphysematous type, mosaic percussive sound, rough breathing, and so on. On X-ray, there is mostly interstitial type of pneumofibrosis, and here is the set of peculiarities I specially highlighted for you on this slide. Contact with coal dust during more than 15 to 20 years. This means that as opposite to what we had in silicosis and asbestosis, when it took less time for development of pneumoconiosis. In anthracosis, it develops very gradually and atypically, and it takes much more time until it develops. Then, the concentration of dust should exceed maximum permissible value to make it possible to prove this diagnosis. It's typical for any type of pneumoconiosis and anthracosis as well. Then, clinical manifestation significantly precede or develop simultaneously with morphological changes. Due to the fact that dust particles of coal are relatively bigger than those of silicon dioxide or asbestos, they cause more expressed irritation, damage of mucous membrane, and appropriate clinical manifestation in form of bronchitis first. Then, rather often, anthracosis becomes complicated with bronchiectasis. Then, the next one is berylliosis. It is a representative of hypersensitivity pneumonitis. It was sometimes named as sarcoidosis with known etiology. Many of symptoms of berylliosis are very similar with sarcoidosis. As you can see, the maximum permissible concentration of beryllium is very extremely low, many times lower than any other dusts of other pneumoconiosis. This means that beryllium is highly pathogenic, yeah, for the human organism. Here is the outlook of beryllium-containing ore. The main branches of industry in which workers have contact with beryllium include mining and ore preparation, metallurgy, diamonds production, and others. Sometimes it's enough that there is only one-time contact and they could be development of pneumoconiosis even. But usually, this working experience or exposure exceeds 10 years. As you can see, beryllium has multiple effects and mechanisms of influence on the organism, including toxic influence, sensibilization, allergic response, fibrogenic influence, and stimulation of fibrosis, cancerogenic and development of oncological pathology, teratogenic and development of um, congenital malformations. And it has inclination to making depositions in the organism, and therefore there could be delayed development of this type of pneumoconiosis. Here are some illustrations of microspecimens, and I'd like to show you the specific diagnosis. One of specific approaches to diagnosis of pneumoconiosis caused by beryllium dust or berylliosis is making Curtis test. It's skin allergic application test with beryllium sulfate or chloride with appropriate, you may see here, reaction to this dust, positive allergic reaction. So, the peculiarities of berylliosis are sharp asthenia, hyperthermia at the beginning of the disease. It may develop at low concentrations of beryllium. Then, late development of berylliosis is possible. So-called Monday syndrome. By Monday syndrome, we understand that as soon as there is a sensibilization to it, if a person has weekends, doesn't have work to work and be in contact with beryllium these 2 days, he returns to his place of work on Monday, he feels worsening of his condition. It is called Monday syndrome. He might perceive dyspnea, breathlessness, cough, and even these allergic reactions and so on. Then, extrapulmonary granulomatous inflammation, its reaction of lymphatic nodes and so on, worsening of wound healing, and positive Curtis test. The rest of pneumoconiosis you might discuss and learn independently. Dear students, what questions have you got in any aspects of dust pathology or occupational disease, etc.? How can I help you with this? Do you have any questions?
No, teacher, thank you so much.
Mhm. So I hope, tell me please, have you already started your practical classes in occupational disease or not yet?
What, teacher?
Have you already started your practical classes in occupational diseases or not yet?
Not yet, teacher.
Oh, okay. So I hope that next time we meet with you, I'll deliver the lecture properly because frankly, now I simply do not have any other electricity and any other connection except my very poor mobile connection. Okay?
No problem, sir.
Thank you for coming. I'll upload this recording of the lecture to the YouTube channel and send you links to these presentations in order to make it more comfortable for you to use all these materials. And also, you may feel free to contact me directly with any questions, especially if you have any interest in our collaboration in the field of scientific research in occupational diseases or in internal diseases. I have introduced this at the beginning of today's lecture and in the presentations. Thank you for coming. Good luck. Keep healthy. See you soon.
Thank you, sir. You too, sir.
Thank you. Thank you a lot. Goodbye.